pharmaceutical is sponsoring me, so there is no traditional conflict of interest. But for this talk, I do have a personal conflict of interest, and that conflict is I love exercise. Okay, so that's a very vital part of my life. So if that's the bias I hold towards you, towards this topic, then that's my bias. Okay, so whether it's running or cycling or whatever, it's a very integral part of my life. So that's my conflict of interest. Okay, so you talk about exercise is medicine. Okay, so imagine if you had a new drug discovered by pharmaceutical companies, okay, which could reduce the risk of heart disease by 40%. All right, and these are all real numbers. This is not something which I made up on the flight over here. Lower the risk of stroke by 27%. Okay, pretty much the two leading causes of death worldwide: cardiovascular disease, which is heart disease, and stroke put together. Diabetes by 50%. Okay, India is the world capital of diabetes. High blood pressure by about 50%. High blood pressure and smoking are the two biggest risk factors, killers in the world. Okay. Mortality of breast cancer by 50%, colon cancer by 60%, okay? So obviously, and some Alzheimer's by a third. So if something like this ever came out, clearly this would be the best selling and largest selling drug in the world, and pharmaceutical companies would make great money. Guess what? It's already out there, and this is all it requires, okay? Which is a pair of shoes. And now, frankly, with the way running is going, and people like Venkat don't even wear shoes and they run. So now this is going towards barefoot. So maybe you don't even need this. Just put a pair of feet out here next time. Not even shoes. Okay. So exercise has all of these effects. It is without doubt shown to both prevent and treat almost every chronic disease there is out there. Certainly heart disease, certainly stroke, several types of cancers, prostate, breast, colon, all of those. Okay. Depression, Alzheimer's, almost everything you can name, exercise is a preventive measure for it, and to a degree a therapeutic measure for it as well. Okay, so much so that there's a whole movement now in the US called exercise is medicine. Okay, that's why we get the title, exercise is medicine. I was at a talk last year by head of Kaiser Permanente. Kaiser Permanente is one of the largest health maintenance organization in the US. They call them HMOs on the whole of California and all of it. And they have come up with this thing of exercise being a vital sign. So when you go to a doctor's room, they must get your, depending on the condition, but almost always they'll get your temperature, pulse, respiration, all of that. So these are called vital signs. Now they've added smoking, which today in the US, almost every doctor you go to will ask a patient on every visit, do you smoke? Whether they've come for, to deliver a baby, or they've come for heart disease, or they've come for a cough and cold. That's a question that has to be asked. So they are saying that exercise must be asked. At every visit, you must ask your patient, do you exercise? And if you don't, why not? If they say yes, then you just have to give a pat on the back and say, please continue, right? You don't have to add anything more. And this is one of my favorite lines, right? Anima sana in corpore sana. This is a Latin phrase which just means a healthy mind and a healthy body. Okay, runners will recognize this. Okay, look at the first letter of each of these, of each word. A-S-I-C-S, right? What is A-S-I-C-S? Essex, okay? It's one of the best shoe manufacturers for runners in the world, okay? A sound mind and a sound body, so that's important. The father of medicine, okay, Hippocrates, in the 5th century BC, also pretty much had the right idea way back then when he said that eating alone will not keep a man well, he must also take exercise, for food and exercise work together to produce health, okay? And this is a picture of a sculpture of David, who was made by Michelangelo in the 15th century, as the perfect man that ever existed, okay? And if David was to be made today, I think he would look more like this. Okay, so, I mean, clearly worldwide, I mean, it's not in this audience, but all across, this is what's happening to our David, okay? At the same time as Hippocrates spoke this, another event happened, okay? Roughly around 490 BC, the legend goes that when the Greeks were fighting the Persians, they won the war and they sent a messenger. His name was Philippides, and Philippides ran from where the war was in Marathon, on the plains of a town called Marathon, to Athens to say we won the war, we won the war. And that distance was or is 26 miles, okay, which is the size of what we call the length of the modern marathon today. And legend has it that Philippides sort of reached the end, he gave the message and he died. That was your first sudden cardiac death during exercise that happened. Okay, but actually if you really read history, apparently that's just legend. He didn't really die. But there are versions where actually he went on and he delivered many more messages and many wars, and he lived on. But the common sort of folklore is that he delivered the message, did the 26 miles, and he died. I actually got this from the European Heart Journal. And this was a painting done by a famous, I think it was a French painter in 1869 to commemorate this. So what would be the right amount of exercise? Okay, and I'm just going to spend very little time because I think a crowd like this doesn't need to know, doesn't need to already knows enough about this. First, let's just distinguish two terms, which is exercise and physical activity. And though we use them interchangeably, they're not the same thing. Okay, because physical activity is any body movement which ultimately produces energy. So anytime, so if I'm standing here, I'm talking to you, I'm raising my hand, I'm walking a little bit back and forth, that's physical activity. But clearly that's not exercise. But exercise is a more structured, planned physical activity. So if I walk from here till the end of the street where this fair is going on, that would be physical activity. That won't be exercise. But if I continued walking for another 25-30 minutes at a brisk pace non-stop, then sure enough, that might be called exercise, or that would be called exercise. Right? So there's sort of a fine line between what's physical activity and what's exercise. And both of these are important. When we're dealing with our patients, we're dealing with people, we're all very good at preaching exercise. But what we forget is physical activity is also very important. Because most of the people you end up dealing with are these sort of executive class of people whom, somebody else does their work all day long. There's a servant at home, there's a peon in the office, there's a driver, etc., etc. So they get very little physical activity, and then they go to the gym and walk on the treadmill or run on the treadmill for half an hour and feel very happy. There's nothing wrong in that half an hour on the treadmill. That's excellent, but that doesn't substitute 23 hours, 30 minutes of inactivity. Okay? So if you're prescribing exercise, a simple way to remember is using the word FIT, or the acronym FIT, where F is for frequency, how often, I is for intensity, how hard should your person exercise, T is for time, how many minutes, and the next T is for type, what type of exercise should you do. So to sum it up sort of in one slide, your frequency should be pretty much ask them to do something every day if it's moderate, right? So what's moderate? Taking like a brisk walk. If someone's taking a brisk walk, ask them to do it every day. 30-40 minutes every day is fine. But if someone's doing something more intense, they're actually going out, running, pounding away, they're playing a game of squash, badminton, those kind of things, then maybe 3 to 5 days a week would be ideal. They do require at least a couple of days off for their musculoskeletal system to kind of recover. How much time? The guideline is roughly 30 minutes of moderate intensity on at least 5 days a week, or 20 minutes of vigorous intensity on at least 3 days a week. Now please, these are the minimum guidelines. We're not saying do only 20 minutes. 20 minutes is like the sort of a minimum threshold cutoff. Intensity, how hard? If you're going to look at heart rate, then 60 to 85% of maximum heart rate on a treadmill test is the way to go. There are other formula, there's something called a Carbonen equation, we can play around with this, but this is a simple rule of thumb, 60 to 80-85% would be fine. Doesn't mean if you go to 90% something bad is going to happen to that person all of a sudden, but time and intensity are inversely proportional. So the harder the person goes, the shorter is the time that they'd last for. So we need to get that sort of happy balance between the two. Duration, roughly 20 to 60 minutes, is for good health. Now obviously if someone wants to run a marathon, etc., at some point they need to do more than 20 to 60 minutes. Not every day, but certainly on their long run days, things like that. And that's okay. These are just basic good health guidelines. The other thing which people often ask and doctors ask is that why not just do a brisk walk? What's sort of wrong with that? And this was a paper by Barry Franklin, somebody I sort of consider one of my gurus, and I meet him quite often, talking about comparison of cardioprotective benefits of vigorous versus moderate intensity aerobic exercise. And the cutoff typically is it's 6 METs. Okay, 1 MET is a metabolic equivalent. That's the amount of oxygen you consume at rest, which is 3.5 ml of oxygen per kilogram body weight. Sometimes when people do stress tests and they show you a Bruce protocol result, they'll write patient exercise for 8.5 METs, 10 METs, 11 METs. So that would be 10 into 3.5 means 35 milliliters per kilogram per minute. Okay, so 6 METs is like a brisk walk. Okay, 5 or 6-ish kilometers per hour, a brisk walk. So what did these people find? I'm just showing you the last sort of summary. It said that exercise performed at a higher intensity appears to confer added cardioprotective benefits even when the total energy expenditure is held constant. Because many people said, you know what, all this doesn't matter as long as you do the same distance. So if you did 5 kilometers, whether you walked it or you ran it, you'd kind of get the same health benefit. And that was also some of the people's thinking. But they said, you know what, vigorous exercise does give you slightly more benefit. There is no doubt about it. All right, so that's something to remember. Another lovely paper which summed up this topic, and this is really nice take-home advice for everybody, is that at least 30 minutes of moderate intensity physical activity on most days of the week would be a good starting point for those who are sedentary. Okay, so your patients, clients, if they're doing nothing, ask them to do something. That's a great way to start. However, when previously sedentary individuals can adopt this regimen comfortably, they should strive for the goal of more vigorous exercise provided there are no contraindications. Okay, so I live near Marine Drive in Bombay, and you see these people for years and years and years, they're just walking at that same pace and they're wondering why they're not losing weight, why they're not getting healthier. So once you're doing that 30-40 minute walk regularly, why not try and do it faster? Why not throw in 1 or 2 minutes of running to try and go to the next level, provided there are no contraindications, okay? So if somebody's, the big message is make people who are doing nothing start doing something. Once they're already doing something, there's absolutely no harm in asking them to take a step further, okay? They'll feel better as well. This is interesting. You know, we talk about exercise and physical activity. Today there's a lot of research happening on the ill effects of being sedentary. So what they find is that the number of hours you're in a sitting position, and that applies to a lot of doctors, right? That's how you spend most of your day, is bad for you, kind of irrespective of the other exercise that you do. So even if you're a regular exerciser and you're sitting for many hours a day, that's not good for you. So people are talking about having standing desks. Okay, so just standing is better than sitting, and I'm trying to get one for myself. This doctor, okay, his name is Mike Roizen, and this is at the Cleveland Clinic. This is the wellness center, so lovely, nice background. And you may not be able to appreciate this, but he's on a treadmill desk. So he's actually on a treadmill, and there's a desk built around him. I met him not last month, in June. There's a little desk built around him, the laptop and everything. And the treadmills at about, he told me that at about 2.2 kilometers per hour is sort of slow enough where you can do all your work without, you know, and he's not doing this 8 hours a day, but he's maybe doing it 2 hours a day. Okay, and he's written a book also. Have you heard of Dr. Oz? He's got a medical show. So Dr. Oz and Mike Roizen have written books together. So he gave me one of his books as well. So this is a net last month. So if I had to sum up the cardiovascular benefits of exercise in one slide, okay, this slide really says it all. And frankly, each of these points you could have 3 slides on it. But you know what, in interest of time, what could be 30 slides are sort of made into one, okay? So it's got anti-atherosclerotic properties. So we know that atherosclerosis is a process of formation of the plaque or the blockage, okay? So it helps against it by improving your lipids, your cholesterol, which is a risk factor, your blood pressure, adiposity, fat. It increases your insulin sensitivity, because we know that insulin resistance is the starting point of diabetes, heart disease, etc. Okay? Decreases inflammation. It's got anti-ischemic effects. Exercise decreases your myocardial oxygen demand, okay? Because the heart is ultimately a muscle. Increases coronary flow. It decreases endothelial dysfunction. Your endothelial is the inner lining of the artery, and the start of atherosclerosis starts from the endothelium having a problem. Anti-arrhythmic. Your vagus nerve controls your heart rate. It increases your vagal tone. It decreases your adrenergic activity. So as you get fitter, your adrenaline rise, the norepinephrine, epinephrine release with exercise comes down. It decreases the thrombotic effect. So it's anti-thrombotic. It decreases platelet adhesiveness, the platelet stickiness, increases fibrinolysis, and decreases fibrinogen. So all of these effects, or good effects, exercise has got, okay? So all of this, I think, to some degree you knew. Now let's talk about something which may be a little bit different, okay? Adverse effects. So you see things like this. So this was in Time magazine, I think about 3 years back, the myths about exercise. Though this frankly spoke more about weight loss rather than dying. But then here, the Telegraph, England had this, too many marathons can kill, warned doctors. So is this true? You know, you hear of people dying while running. So is there some truth to that? In February in Bombay, the Thane Marathon, there was a death during the half marathon, okay? One young executive died. And this was the sort of headline in the paper a few days later, and that's when I wrote a sort of a blog on risk of death during marathon running. And I've been writing for a long time, and hardly anybody looks at my blog, but I write something like this, and like 3,000-4,000 people look at it, within a few weeks. So there's a lot of interest in this. And so what is the reality? There was a paper in the New England Journal of Medicine titled Cardiac Arrest During Long Distance Running Races. This was last year, and it looked at 10-year data in the US. Okay, so I'll show you the results. It looked at 11 million runners. Okay, so clearly this is not a small amount over a 10-year period, and they found that there were 59 cardiac arrests. Cardiovascular disease accounted for the majority of all these arrests. The rate of cardiac arrest, if you look at per participant, was 1 per 1,84,000 participants. So it's not like every second person is just sort of running and dropping dead. And the rate of death, so these were some of them survived, was 1 per 259,000 participants. Okay, so extremely, extremely, extremely low. Okay, I tell people that if somebody dies during the marathon, the next day the paper will say died in the marathon. If somebody dies on a treadmill, young BPO executive died on the treadmill. But that same fellow was sitting at home drinking beer and eating chips, and he died on his sofa. It won't be a headline next day. Young executives at home watching TV dies of a heart attack. So my point is that the press picks it up and it gets dramatized more than it needs to. Okay. These are again other studies, different studies looking at different marathons, London Marathon, Twin Cities Marathon, and to sum it up roughly, the numbers are very similar to what I just showed you. Okay, what's our experience? I'm the medical director of the Mumbai Marathon. We've been doing it now for 10 consecutive years, and in the overall marathon, there have been no deaths in about 7,500 finishers that we've had. Okay, this is the full marathon, 42 kilometers. In the half marathon, we've had 1 cardiac arrest so far, which happened this year, okay? And touch wood and everything else that we can touch. It's a combination of luck and hopefully preparedness. We actually saved the guy, which is very, very rare. So cardiac arrest means the person's pretty much dead. If you don't get to them in a few minutes' time, they're not going to live. And this, for those of you familiar, many of you I know do run. This was at near Babulnath in Bombay. So from, I would say, about 15 kilometers into a 21 kilometer race, and the ambulance got him on time. He was taken just to hospital, and he had an angiography within an hour. So I've been joking with people after that, is that if you want to have a heart attack in Bombay City, have it on marathon day, because that's the only time you'll get help within a few minutes, and the roads will be like yours to take you and transport you. Otherwise, those of you who live there or who visited there, you know that you're not even going to get to help within an hour. Forget getting an angiography in an hour. In the second year, we had one very old lady, 77 years old, with heart disease, who shouldn't have been running, who actually died. And I put one death question mark is because she really shouldn't have been there. The sad part is her name was Kokila Ben, and that was like also Anil Ambani's mother's name, because he had run the race the year before. It was a big hoo-ha, and the press said Kokila Ben running, trying to make everybody think that is his mother. And this lady bichari got more sort of chadawed, and people pushed her on, and she within 1 kilometer only collapsed. And it turned out that she was somebody with a heart problem being treated. Doctor said there's no way you can even go to 2 kilometers, forget doing 21. So that's why I put that one death in question mark, because though yes, she did die, that really wasn't a genuine running death that occurred. Okay? So putting into perspective, if you look at risk of sudden cardiac death, okay, SCD, sudden cardiac death in the US, per 100,000 population, cardiac related is 40 per year. Okay, marathon related is 2 per 100,000. In other words, 0.0002%. Okay, so your risk of dying while running is exceedingly low. That's bottom line message. The other interesting thing is looking at sudden cardiac deaths in athletes in relation to age. I remember very, very clearly a Nigerian footballer died in Goa, I think in 2010 was it? And they said that the goalie hit him on the chest, so he collapsed and died. And the people always write, footballer had heart attack. It's not a heart attack. All these guys, firstly, it's a cardiac arrest, and when it happens in a young person, typically below 30, it's happening largely because of a condition called hypertrophic cardiomyopathy, which in medical, we write HCM, right? Hypertrophic cardiomyopathy. That's the commonest cause of death sudden death in young athletes. Okay, 2-3 US basketball people have died. And that is just the heart swelling up and unable to pump out enough blood, and then it suddenly gives a dangerous rhythm and the person dies. And this can be picked up very easily on an ECG or on an echo. So Italy is the only country that I am aware of which screens all its high school athletes also once they get to a certain level. Okay, US they don't do it yet. Over 35 coronary artery disease means the blockages is clearly the commonest cause of death. And India we are having heart disease blockages at even younger ages. So I would say in India maybe even a 27-year-old could be blockage rather than hypertrophic cardiomyopathy. But typically below 30 will be hypertrophic cardiomyopathy, or sometimes they have their heart arteries arising from different places, which we call anomalous coronary arteries. Okay, those are the common ones. Again, interesting thing is they saw these people, 45 subjects who died, but within a week they looked back and saw that most of them had some warning sign. Chest pain, increasing fatigue, indigestion, heartburn, excessive breathlessness, ear or neck pain, vague malaise. So they had what we call prodromal symptoms. Most of them had something. Now, of course, as a doctor, if a runner comes to you, 2 days before a run and says, "I'm just getting some ear pain," you're not going to say, "Okay, every ear pain means suddenly something's going to happen." So, frankly, it is difficult. What do you do with that information if someone comes and tells you, "I'm getting ear pain 2 days before the marathon"? You would say, "Take an antibiotic and go and run," right? That's a common sense answer. But just start telling you that they're getting heaviness, breathlessness, that's important. And the important thing is, you always look at changes. In every person, breathlessness, etc., the relative is very important. Because somebody might be running 10 kilometers regularly, and now they start feeling breathless at 8 kilometers. That's an odd thing. While somebody who's normally running 3 kilometers, you make them run 5 kilometers, all of a sudden they feel breathless. That's normal almost, right? So it's absolute versus relative. So in runners especially, try and look for changes over time. That's your biggest clue. That is, the person says, "Nowadays I'm getting more and more tired, more and more tired." That's your big warning alarm bell. You need to do something about it. This is a complicated slide of what happens. I'll just quickly walk you through it. Bottom line at the end of it all is because of increased ventricular ectopic activity, right? Because your ventricular, so the guy gets premature ventricular contractions, you get ventricular tachycardia, and you ultimately get ventricular fibrillation, which leads to death. And the different pathways that go to it, including abrupt cessation of activity. This all of us, many people who run are guilty of. You go all out and you finish and then you suddenly stop and you don't cool down and the blood sort of pools down in the legs, and that can be dangerous sequelae of that. Okay, sodium potassium imbalance. A lot of people are taking extra fluids also sometimes on long runs, so they get hyponatremia. Okay, rather than dehydration, they get excessive water and then they get low sodium. So all of this ultimately leads to ventricular ectopic. Now, what else happens? When people have plaque in their arteries, exercise sometimes causes coronary artery spasm in disease segments, which leads to plaque rupture. Exercise can also cause a change in cardiac chamber dimension, twisting of the coronary arteries, which again leads to plaque rupture. Okay? Sometimes there are what we call increased blood pressure leads to shear forces, which causes your plaque disruption. And also there's an augmentation of the catecholamine platelet aggregation. Excess catecholamines are secreted, platelets aggregate, that causes your thrombus. So this is a thrombus happening inside the artery. However, when you look at the relationship of exercise and sudden coronary death, what they found is that people who are sedentary, now this is an important concept to sort of understand, sometimes it's confusing. People who are sedentary, their risk of having sudden cardiac death is much, much, much higher than people who are active. But even somebody who's active, when they're actually exercising, for that 1 hour, 2 hours, their risk goes up compared to their baseline risk. Okay, so I'll give you an example, and the numbers I'm quoting are all just made up numbers, but just to make you understand. Let's say somebody is sedentary and his risk of having a heart attack is 10%. Now you send him out on a run. During that run, it might become 12%. Okay, so it's increased compared to his baseline. Now say we train him for 6 months. Now his risk of having a sudden heart attack may be 5%. But if I send him out on a run 6 months later, during that 1 hour run, that 5% becomes 7%. So you understand? Exercise, an acute bout of exercise will increase your risk, but it lowers your baseline so much that ultimately your overall risk is much lower. So whenever the press and all, they call you and you giving them quotes on this, it just becomes a very difficult question to answer, because if you just say that during exercise your risk actually increases, and you don't take the whole context into sort of picture, it can sound very odd. Which is also why they tell you to discourage weekend warriors. People who do nothing, suddenly they wake up when they're 40 and they say, oh, let's go, I don't know, Goa example, let's go trekking up the Dudhsagar waterfalls or someplace, you know, which they've never done before. Okay, so that person you have to be careful of. So what are the guidelines for screening people? Okay, these are the European guidelines, and I'll just kind of walk you through them. I've got the actual paper in my bag if anyone wants to look at it. So if somebody is sedentary and they've not done any exercise before in their life, etc., and they want to do low intensity activity, sedentary, and this is for middle age and older people, so they're counting at 35 and above, and they say, I want to just start walking. They can do a self-assessment. So very simple questionnaire, you know, what they call PAR-Q, which are like 7 questions. Do you feel chest pain when you exercise? Do you feel breathlessness, etc., etc.? The person can answer it themselves. And if they say no, 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 everything is fine, then they can just do their exercise without any further evaluation. Supposing they say yes to some of those questions, then it's a good idea for the physician to look at them and to evaluate them, do a basic ECG. Physician says it's low risk, fine, no problem, exercise. Physician says person is high risk, then do a stress test. Stress test negative, no problem, exercise. Stress test positive, further evaluation. Okay? Same way if a person wants to start moderate intensity or high intensity activity and they're sedentary to start with, let a doctor look at them straight away before they start it. On the other hand, if somebody is already active and they want to do low intensity activity, let them do it straight away, no problem. If they want to do moderate intensity activity, let them do a self-assessment of risk. If the answer is no on every question, let them start. If the answer is yes, let a doctor look at them, and again same thing, low risk, start straight away, high risk, do a stress test. Stress test is clear, let them exercise. Stress test showing something wrong, check them out further. Okay? High intensity activity, straight away let them do a physician evaluation before starting. Some of the common ECG abnormalities seen in the athletes. Okay? Common is sinus bradycardia, first degree AV block, incomplete right bundle branch block, repolarization. Okay, QRS voltage criteria means increased QRS, which sometimes indicates left ventricular hypertrophy. This is seen in commonly. Rarely is things like T-wave inversion, ST segment depression, complete LVBB, long or short QT intervals. So these things are not very commonly seen. So if you see these, then you need to sort of evaluate further. Okay, this is something interesting. I met these people today also, or rather today. In Goa itself, there is this company, okay, this startup called Callo. These people have come out with this unit, and this is how it looks. A small little unit. It connects to a 3-lead ECG, and it connects to your smartphone. So it's really convenient, and they made a little assembly. There's somebody actually doing it. They've put a little pouch around the waist, and this is his phone. This is a regular phone. It's not a special instrument. And from his chest, the 3 leads are coming into this one, and his ECG is running real time. And the beauty is, I've seen some of these before. In fact, Israeli companies make it, but I've never seen one where the ECG stability is so fantastic. So this is ECG while he's actually walking away and everything. Very stable, right? Those of you who look at ECGs often will sort of appreciate that. And I want to do it now more and more in Bombay. We're going to start testing on some of our people. Okay. So the last bit is there something like too much? Okay. You'll often hear, especially in lay public, this guy exercises a lot. He's an exercise. He's a fitness freak. Somehow I hate that word also, fitness freak. I'm on this new movement that we should stop using the word fitness freak. We should say sedentary freak. He's a, fitness good guy, or some other word which a positive word associate with fitness and a negative, right? Fitness freak sounds so bad. Freak is a bad word. So we need to change that message to society, okay? So is there something like too much? And in New England Journal, this was when it was published 1986. So Pfaffenbarger, who's considered the sort of father of activity epidemiology, came out with this thing called the Harvard Health Study, or the Harvard Alumni Study. And they looked at 17,000 Harvard alumni who graduated roughly in the 20s and 30s from Harvard, and they followed them for several years. Okay, and from 1962 to 78, they saw how many deaths there were. And as you doctors know, the more deaths there are, the more powerful a study becomes, because then you can really see the causes, etc. And what they found is interesting, okay, this is 1986. Death rates declined steadily as energy expended on physical activity increased from less than 500 calories per week to more than 3,500 calories, beyond which rates increased slightly. So you kept having a proportional decrease in death, And beyond the 3,500 calories, which is a lot, 3,500 calories, rule of thumb means 35 miles, okay? 35 miles is what? About 50 odd kilometers per week of physical activity, including normal walking, running, all of that. Beyond that, they found that there was actually an increase in that. So therefore, again, you have this was from New York Times Wellness column, July 24, 2013, which is not, less than a month ago. Can you get too much exercise? This article, which has become sort of legendary in runners, and everybody's forwarding it to me, and this guy's got a YouTube video on TED Talks also, James O'Keefe, potential adverse cardiovascular effects from excessive endurance exercise. Firstly, nobody has defined what is the meaning of the term excessive, okay? But typically these are in what we call ultra endurance runners, which very, very few people frankly in our country are, okay? There's no cutoff, but I would say somebody who is what? Routinely logging more than 100, 150 kilometers per week on a routine base, not on a given week. Okay, every week they're knocking off 100 plus K. Would you agree, Dan?
Absolutely.
Yeah? Would that be a reasonable cutoff, saying 100 K per week? So if somebody runs 5 times a week, so 20 kilometers each time you run, you're doing that week after week, that's a high level, okay? That and upwards. So again, very few people fall into that category. So you don't need to worry that just because someone's training for a marathon, they don't become, ultra endurance runners. So what they found that intense endurance exercise induces acute right ventricular dysfunction. So far we keep concentrating on the left ventricle, while largely sparing the left ventricle. Interesting, the left ventricle remains kind of fine and healthy, the right ventricle is getting bad. Long-term training for extreme endurance exercise may, and that's why I use the word in capitals, lead to myocardial fibrosis and remodeling of the myocardium in a small subgroup. Okay? So if we are men and women of science, and because we love something, we mustn't be blind, and so whatever you do, exercise can never be bad for you. Maybe. There's a bunch of stuff coming out saying maybe if you're doing that volume, there could be some adverse effects. One of them is causing atrial fibrillation. Okay? They found that 5-6% of endurance runners have atrial fibrillation. But then sometime later, another study came out saying 5-6% of the normal population in that same age group also has atrial fibrillation. So then, is it so bad? Okay. So, but at the same time, we shouldn't, ignore. This myocardial fibrosis may be a substrate for atrial and ventricular arrhythmias. Okay. Very, very famous runner, guy called Caballo Blanco. This whole book called Born to Run was written about him. He died last year or a year before last, while out on a run in New Mexico in America. Okay. Now all runners say, "Hey, what a way to go," and all that. But that's, that's just one way of looking at it. Ultimately, a death is very traumatic, and that's not a great advertisement for endurance running when the hero of the book dies during the run. Okay. So they also found that intense endurance exercise often causes elevation in biomarkers of myocardial injury. So when somebody's got a heart attack, we send them and say, do a troponin level. But guess what? They did troponin levels on people who finished comrades and other such runs, and they found it very high, almost for a week. And then it settled. So does it reflect pathology? Is that a bad thing that the guy's troponin was high after that long run, but then 1 week later it was okay? We don't know that. Okay? But these things are happening. So let's not also be blind and just say, oh, we can do just what we want and absolutely nothing can happen. And this is only wonderful and, all this is nonsense. That's not true. Things can happen. Alright? There's this one, well-known guy, he spoke about, he saying that there are findings that suggest that vigorous exercise may be pro-arrhythmic in the atria and they may be anti-arrhythmic in the ventricles. Okay? So again, interesting stuff that's coming out. Then they're also looking at doing magnetic resonance imaging, MRI, for the heart. And they found that 6 out of 12 veteran runners, they had this pattern of myocardial fibrosis. Now please look at what they've done. Mean age 57, years of training between them 43. Marathons that they run between this group 178. Okay, so each of these guys has done on an average 178 marathons. So we're not talking about just sort of you and I and the regular Joe. Okay, they've done 65 ultra marathons. So these are like hardcore runners. And they found that some of them had this myocardial fibrosis. Another study looking at that 12% of apparently healthy marathon runners had myocardial damage as evidenced by the MR. So last month again at the ACSM talk, the guy who's the world leader in MRI for athletes, guy called Andre Lagos from Australia, he was talking. He's a young guy and he showed his own picture. He's like a 2:24 marathon runner. Full marathon, please, let's clarify that. Okay, because we are in India, when we say marathon, everybody is very happy to think it's only half, but this guy runs 42 kilometers in 2 hours 24 minutes. And he did it on himself. And he had scarring. So he's saying, I don't know what to do with this data. Because we don't know, is this scarring temporary? Is it transient? Does it go away? So I even stood up and asked him, so should we do it on all our ultra? People saying, no, at this point, no. Not as a routine thing, because we don't know. In medicine, we do so many things. We may not necessarily know the consequence of it. So what if I see scarring? Does that mean this guy should never run? I don't have data which tells me that. So that's where we are at. Okay, but these things are happening. The question is it benign? Is it a benign physiological adaptation, or is something more going on? All right. So if we need to conclude, we need to say, or we can say that the benefits of exercise in the treatment and prevention of chronic diseases are clearly proven. Okay, I don't think anybody, especially not in this room, would disagree with that. The event rates for those participating in marathon running is very low, which is basically one death per 259,000 runners. Regular exercise provides protection against sudden cardiac death during exertion. There's no question of that. There is some evidence emerging that there may be adverse cardiac changes related to very large volumes of endurance training, and some suspicion that all of what we call athletes' heart may not be entirely physiological or beneficial. Okay, the same thing we spoke about, the myocardial fibrosis, changes in the right ventricle may lead to some arrhythmias. However, this is an important point. As of now, this is not important as a public health issue. But this is like one microscopic segment of the general population. Because what happens is, I think, maybe politically incorrect to say, but as a society, we are fairly lazy where exercise is concerned. As a society, we're not culturally inclined towards exercise or running. So everybody is very happy to ever read a study like this, or the fact that someone died, to say, see, I told you, just quietly do a little walking and yoga and you'll be fine. You know, forget all this running, shunning and all. Which is not true. So as a public health message, this whole adverse thing is a very minuscule part. In a given individual who you may need to counsel, you can bear all of this mind. Okay? So I always like to finish my talks with this positive, sort of pictures. This is the Bombay Marathon, and every year from 2004 we've had our heart disease patients, people who had bypass surgery, people who had angioplasty take part, and they've been doing the dream run, which is 6 kilometers. The last 5-6 years we've had about between 15 and 20 people even in the half marathon. And it's become so popular that now we said, okay, this year maximum we take 75 for the dream run and 25 for the half marathon. So every year this is year after year. So you might recognize this young man standing in the center of this photograph out here. And this was, I think, 2013, this year in January. So thank you. And if you have questions, I'll be happy to answer them. Thank you.
How do you manage a runner who collapses followed by dehydration?
Okay, how do you manage a runner who collapses? Okay, that's a great question. The first thing I would see is whether he is conscious, right? So the first thing to rule out is he having an arrest, right? So we look at the airway, breathing, circulation, ABCs, no circulation, etc. Then you go into your arrest algorithm, okay, which is immediately starting CPR, try and get a defibrillator as quickly as you can, and go ahead and do that. Anybody who does medical for the Goa run out here, sitting in this room right now?
No.
Okay. But you all must have defibrillators and all those things. I mean, whoever is doing your medical, make sure these things are there, okay? Because that's the only thing that can save the life. Okay, so you start with CPR immediately, wait for the defibrillator till arrested. If it's just a question of dehydration, today what is interesting is often the symptoms, signs and symptoms of dehydration are very similar to those of hyperhydration, which is hyponatremia. So first you try and figure out, is the guy, can he talk to you? If he can talk to you, is he coherent? If he's talking gibberish, then that's clearly more. Try and ideally you take a rectal temperature. That's not an easy thing that we do. Often they may even feel cold to the touch because their CNS is actually shutting down. Though they are hot inside, to the touch they may not seem that hot. Cool them as quickly as you can. So take a lot of ice. I mean, ideally dunk them in an ice bath, but not that you have an ice bath everywhere. Just put lots of whatever, napkins, towels, etc., and ice water, and put them on all the extremities everywhere. Try and cool the guy as quickly as you can. Often we start IVs, just normal saline on them.
How much to hydrate? Because you, in a marathon setup, you will not be able to assess the person.
Maybe put 1 pint, give him 1 pint fluid, and by the time you see the guy starts recovering, then that's fine. Keep assessing the white
Rate
rates.
of the drip.
We normally give it over half an hour. So I can give it a little bit quicker if you find there's something there. Normally over half an hour.
The famous study was done in London, importance of sedentary type of life and exercise only. The gentleman died, I think 2 years ago at the ripe old age of 90 plus.
The one fellow did the bus conductor
Bus
study?
conductor study. And the driver.
Yes.
And they found, he found that the incidence of heart problem was much less in conductors.
Correct.
Those who went
Absolutely.
double-decker bus.
Absolutely. So
so it's mental stress or physical inactivity.
Yes.
The driver, or maybe under mental stress of driving.
I never
but
heard anybody
he
make
was-
that point. That is interesting.
But he was sedentary
That-
relatively
yes, yes.
Compared to the
Yes.
conductor.
Morris
who
was the guy.
Morris, and he was very enthusiast about himself
Yes.
of exercise.
Yes.
And he died at the ripe old age of 95.
And probably was healthy.
And
till the end.
he was
That's
very
more
used to
important.
swing,
Yeah. Great.
regularly.
Thank you. That's great. The study he talks about is very interesting. This was done in 50s, I think. It was done almost called the London bus study or the bus conductor studies. Okay. Now, in any study, ideally, we must have two groups of people who are as similar to each other as possible. This guy did a very simple experiment, very elegant. He looked at bus conductors and drivers. Bus driver and bus conductor. Now, they pretty much come from the same socio-economic strata, their type of work, everything is same. But the driver is sitting all day, while the conductor is walking up and down all day. So they looked at drivers and conductors, and they found that the drivers died earlier than the conductors or had worse health outcomes, more heart attacks. So that was one of the first studies which came out talking about physical activity. Thank you. Yes.
There was a comparison between brisk walking and jogging.
Yes.
So there was a book, I forget the name of the book, but it is a well-studied book. It says that jogging creates more problem than brisk walking. And the brisk walking, if you get the target heart rate, which is about whatever you calculate according to the weight and age of the patient. If you brisk walking, you can target that heart rate for 15 minutes is as good as jogging. Because jogging is an impacting exercise.
Okay. So thank you. It's a great question. But that question will take a little time to answer it because it's got many nuances thrown into it. There's not a simple answer to it. Okay. So let's look at sort of each angle of it. So firstly, if you look at the heart rate angle, right? So if you say that as long as you get the heart rate up in brisk walking. Now let me put it to you this way. Let's say you have a sedentary person and we want him, we say 70 to 85%, we can agree on. Okay, he's never done exercise. Today you send him for a brisk walk, and let's define it. His brisk walk today, which he might cover a kilometer in 13 minutes, 12, 13 minutes. Okay, it's a very realistic number I'm giving you. And he does that, and his heart rate is 83, 84%. Okay, then he does that for a few days. Now he's doing it at 11 minutes. Okay, and now his heart rate may be 80%, and he's doing it again and again. Now he does it in 10 minutes. Okay, which is 6 kilometers per hour. Now, faster than 6 kilometers per hour, it's difficult to really walk. There are some taller people who can walk in this manner, who can do maybe 9.5 minutes per kilometer, maybe 9. Right? So now he's doing that for a while. He's doing your 9 to 10 minutes per kilometer. He's been doing it for 1 month, 2 months, 3 months. But now, over time, now his heart rate is dropping. Because within a few months, as a relative intensity, now no more is it in that zone for most people. So one is, he's not in your target zone. He cannot be in the target zone anymore with just walking. So he needs to do something more. Okay, that's one angle to it. The second angle is when they're looking at benefits, which is I showed this study by Franklin and Swain. He looked at all other studies. It's been a big debate about this. And they've said that cardiac benefits, all other benefits are a little bit more, all other things being equal, when the person is doing a more vigorous form of exercise. So running would be a more vigorous form than this. Now again you could throw in the question of what about musculoskeletal? Now again there are studies. So there is this guy, his name is
So vis-a-vis, if you compare the impact,
yeah. But that's what I'm saying.
complications.
So there is, and I'll try and send you the citation. I met the guy, Paul Williams was his name, Paul Williams. He has done, I forget the name of his cohort. He's studying these runners for a long period of time. And they showed, you know what, really speaking, arthritis of the knee or knee replacements are not any more in runners than anybody else, if at all. When looking at large groups of people, 2, 3, 4, 5, 10,000, the runners have less, lifelong runners have less knee problems than people who are inactive. Okay, I mean it's simple. Let's go to any orthopedic practice in Goa, in Bombay, anywhere. Are the people queuing up for the orthopedic? Are they 50-year-old or 60-year-old overweight men and women, or are they athletes sitting in their waiting room? Okay, that's anecdotal, I'm telling you. But in a given person sitting in front of you, he says, "Doc, I'm getting knee pain, early arthritis." You may say, "Okay, for you, let's
Risk
consider
would be
something
better.
else, maybe psych." So you know what I mean? So there isn't an
Really
easy
different.
answer to this. So in your given person, he's tried running, he's having a hassle, every time he runs he gets pain. It's okay, you know, maybe it's not for you. Why don't you do cycling? Why don't you do swimming, or just a brisk walk? So there's definitely benefits in brisk walking, but you know, it's hard to compare. A lot of people also, and again I tell you that for health benefits, you need to do those 3-4 times a week, 5 times a week, 30, 40, 50 minutes. But a lot of people want to go beyond health benefits and sense of achievement. Then again the equation changes, right? If you want to run a marathon, you pretty much need to run. You can't really walk. So that's not
One
the
more
right.
question I want to
Yeah.
ask you. There are some deaths on the football field, as
Yeah.
you mentioned.
Yes.
But our footballers, they train a lot. They're supposed to be the
Correct.
best
So
athletes.
those-
Some
yes.
of the, because
So-
football is one of the quickest games.
Absolutely, certainly more
Yeah.
than cricket, right?
Yeah. Squash, of course, not as good as squash.
No, no. Footballer at a high level, footballer, I mean,
Yeah.
squash is more starts. So both
Next
are
to
very,
squash, maybe. Yeah.
they would, those are deaths due to cardiomyopathies. So those are people who are not, the deaths are not because of a fitness issue.
But are they not doing the necessary? Now, this is not only a local level.
No, they're not tested.
But upper levels
No,
also.
routine.
Even in European football, there are some deaths on the field.
Yeah, but they're not, everybody is not routinely tested. There's no law except
Don't
Italy.
they do the routine test for everybody there?
They don't.
Maybe
No.
here they cannot afford.
No, they
but
don't.
there,
They don't.
European
It's
football
not.
is
It's
supposed
not
to be the
routine.
richest.
No, who does it? Where they do it? That I don't know. The only country until recently
Only
where
Italy.
it was Italy. Okay, and Europe is little more inclined to it than the US. There are, because the argument goes, there are many people who even have some abnormalities and nothing ever happens to them. So do you stop every young athlete with a question mark abnormalities? That's the lacking part of science, na? Which is why even what this is called screening. Which is why today I'm deviating a little bit, but prostate cancer screening, PSA for men, is not routinely recommended. Something which we used to do left and right. Now we are saying don't do it on everybody because there isn't benefit, isn't evidence that by doing it we're actually saving deaths. So the question is, you pick up a guy at 20, is totally asymptomatic, not a problem, and he goes out and you know, he might live on forever. I mean, normal age. But at the same time, the same guy, when he spoke in America, he said, you know what, I had a runner, he had this some scarring, etc., and it's non-specific. I told him it's fine, you can go ahead, and that person died 6 months later. He had the guts to sort of say that. Saying, that's the reality of what we face. What do you do with that information? Where are you being overprotective versus this? I would say as a doctor, your duty at those points would be to lay open the facts in front of the person and give as much truth as we can. We are not used to giving patients decision-making power. And I feel that that can change, where you say, look, this is the thing. And as a doctor, be humble enough to say, look, the truth is, I don't know. I cannot predict whether something will happen to you on the field. I know that when you have this, your risk is certainly higher. You know, I give the example where I was talking to some people. I got a bodybuilder, not a bodybuilder, a power lifter, okay, between 25 and 30 his ages, Commonwealth Games, etc. Some like a medalist level person. He said he had a heart attack in I think late June or early July, and now he wants to get back to competition in September. So I had to tell him, I think, look boss, this is not what I would ordinarily recommend. But he's saying, this is my life. Now, when it's a person's life also, as doctors, they will learn to say yes more than no. So I would say, ordinarily I wouldn't say, but if it's your life and you say, I just need to take part, it's okay if I don't win, and it's still, we got 8 weeks, go ahead. So that balance is a tough one, and that just brings up a lot of questions related to, I don't know, ethics or, philosophies.
One last question.
Go ahead.
With all the adversities,
Yes.
how Ethiopians are winning all the marathons?
That's a good question. I think
Because they have got all the adversities in the world. They are
I
poor
think,
country,
I
no food.
don't think,
nothing.
and those of you who know more about this, please feel free to sort of jump in and correct me. In Kenya also, which is sort of as
Maybe,
famous or more, a lot of them come from certain tribes. So it's not Kalenjin,
Is it
etc.
genetics?
So, yeah. So there is one genetic component, two is the altitude component, etc. So I think it's a bit of a combination between altitude, genetics. The third thing, which I don't think people ever talk about enough, is just the fact that once you know something can be done, it becomes like an Indian child grows up saying, "Chalo cricket khelega," and we'll show India, but because they're all doing it. I mean, look at Jamaica now. What better example you want? Okay, until the recent past, I mean, if I think back, I can think of Merle Naughty. She was the one who opened Jamaican doors. Was there somebody before Merle Naughty that at a really high level? And today, the start line of 100 and 200 meters is like 3,344 out of 8. Or, and who even knew
With
Jamaica?
drugs or without drugs?
No, but even without it, a lot of them have this. So, it's just been, I think it's a combination of genetics and environment, and then the sort of
Mind power.
Mind is to some extent. The mind is to know it's possible. That angle. To know it's possible. It's like when a Kenyan kid grows up, immediately a choice put before him probably when he's 7 or 8 is, why don't you run long and let's see if you're capable of it. When an Indian kid grows up, it's, chalo, yeah, go and bat and let's see if you can run. So that's also a culture, I would say, more than. You can use only one or the other. You can either use bicycle or you can use treadmill. All over India, really 90% of people use treadmills because treadmills are a more natural thing to do. Europe is very bicycle based. Because also in their daily life also use a bicycle a lot more. Bicycle is more unnatural compared to walking. I mean, walking is more natural. So America and in India we use a treadmill. In fact, for VO2 testing, actual metabolic card, first time now in Mumbai we are doing it in a sort of a private setup. There's a hospital called Shushusha, they've set it up. So if any of you all want to ever get tested or you're in Mumbai and you want to, we can do it. We've just been doing it. In fact, Venkat was the first guy who got tested. They want to test him one more time also. So yeah.
Have you come out with any format for specific sports for fitness?
My idea or my answer on that is that the best thing to do is do the sport which the person enjoys. 2 weeks, whoever is registered, and fill in a basic profile of their medical history. So all the names are here. You can just click on anyone and it shows exactly bib number, this.
So if it doesn't fill the criteria, do you?
Framingham. So we are telling people you fall into low risk, medium risk, high risk. So somebody is low risk, we'll say with a disclaimer, etc. Of course, any scoring has got its limitation. That you seem to be low risk, please go ahead, take part. Medium, we'll say, look, you are medium risk. It would be a really good idea to talk to your doctor before you take part. If you're in high risk, we say you really must talk to your doctor before you take part. We don't look at that to then eliminate the person. That is one part, the risk profile. The second part is getting the person's medical data down. Okay, name, age, medicines you're taking, all of it. Now that is super important under the rare event of something bad happening. The guy has collapsed. I know nothing but his bib number. But in 1 second, if I know that he's on certain medication or not, if I know, for example, he's diabetic, then first thought will go to, okay, probably low blood sugar. That will train my thinking in a right direction. If I know he's got a history of heart disease, he's taking this, my first thought will go to, okay, maybe it's a cardiac arrest. So that comes quick. And that, frankly, if I might sort of proudly say so, I think almost no marathon in the world is doing it, or maybe one or two. A little bit of searching at it, I haven't found. We found one, I think Vienna was doing something, one of them, but not like any major business. So that is something which is also useful, and maybe they can do it for Goa as well.
Brings in idleness, brings in disease, while labor and industry wards off.
Excellent. I think that's a nice.
And this is a basic lifestyle also gets associated with your lecture.
Right.
So one has to also think simultaneously about lifestyle.
Agreed.
This in Western population, the study was done by the date of birth. In earlier generation, when the mechanized things were less,
Correct.
and actually people were working,
Correct.
and in those that group of people, and as in America, the obesity is a modern,
Correct.
and that is basically a result of idleness and luxury.
They've done it in China. They look at the number of cars per population and sort of obesity, mechanized transport. I had a lovely cartoon which I sometimes show. They say, what did they say, in 1988, they show like a very big TV and like a man is thin. And then they show like 2008, the TV has become this thin and the man has become this big, as wide as the older TVs were. So yes, as we're getting sort of mechanized, that's happening in our country.
Everywhere.
You see, at least in Bombay city, if you stand in a mall on a Sunday afternoon, just look at all the people going in, especially the women. There's almost nobody whose BMI, what we call body mass index, is anywhere under 25. Just visually look at it. Anywhere where there is prosperity. But the sad part is the other half are on the road begging for food. So naturally, we look at the overall population of India, we really look at everybody, we balance out.
They have extremes. They have extremes.
Exactly. And the have-nots have it here. So as an average, they balance it out. But if you really just stand outside a mall, I say mall because almost everybody again going into a mall is of a certain sort of socio-economic status. All getting overweight. Studies we do in school children. We just, in fact, we got one of our studies accepted looking at school children and pedometers. We actually measured physical activity in school children.
See, you compared brisk walking to running.
Yeah.
How would cycling compare to running?
But see, again, the thing with cycling, so this is not looking at brisk walking, running. That looked at vigorous versus moderate. So that applies to any sport, really speaking. Because even cycling, you can cycle for leisure, or you can sort of race cycle or athletic cycling. Cycling as a general exercise to walking. One thing very nice about cycling is there is no impact. But one interesting thing, again, I heard it on this. Last year I was there for osteoporosis. A little bit shocking that long distance cyclists had more osteoporosis than sedentary people.
Absolutely.
Because there's no weight bearing in cycling. The cycle bears your weight. You don't wear your weight. So, long distance, like Tour de France level type cyclists, many of them had.
Swimming, I think, is the best, no? Swimming.
Swimming is also not, it's not really weight bearing. So I don't know about swimming and osteoporosis. From an osteoporosis angle or the bone strengthening angle, walking or anything sort of which is weight bearing would be very good. Joints angle, swimming, cycling, very good.
What about the Kenyan Ethiopian athlete?
Okay.
The genes, there's something about the VO2 max which is abnormally higher than normal.
But that they've attributed more to living at altitude than anything else. It's not just a genetic. In fact, since this is a topic of interest, what research has shown is that for sprinters, okay, who have this type 2B muscle fibers, you're literally born a sprinter. That's why all the endurance people always grumble is sprinters, Sala, they do no work. They just lounge around the track all day long, do quick 3-4 shots and they go home. Well, these guys are non-stop, hour after hour, just doing round after round after round. So it's almost like saying Usain Bolt when he was born, if you did a biopsy on his muscle, you would say that this guy is world class. So if you're not born with that genetic muscle fiber, you can never ever be a world class sprinter. Whatever training you do.
Nor an endurance runner.
But I think the endurance runner, I think you have a greater chance of being a very good endurance runner versus the sprint. I mean, I think that sprinting is far more pure genetics compared to the endurance. I think endurance, then a lot of other factors are kicking in between the two. So just randomly try to say that genetics in a sprinter may be 80% important while they are maybe 50%. So of course important, but just sprinters are just born sprinters.
Vasco Sports Club. I thank you all for making me talk. And first and foremost, I also want to thank Dr. Aashish for coming down and spending his time. Especially it's passing video tomorrow. So in spite of that, he's come. And it's purely the passion which we can see in him, which wants him to travel to so many places and share his knowledge. I also want to acknowledge the presence of two very important people. There's Daniel Vaz from Bombay. He's a very senior coach for long distance running. And also Mr. Venkatraman, who's a senior chartered accountant and he's on the board of many companies. He had a bypass about 5 years back, and now today he's running half marathons. So he's a living example and inspiration for us.